you only put someone on a ventilator if they were critical. Now, there could be a lot more people would be at risk of secondary bacterial infection. In fact, it would be reasonable for anyone who was severe to have antibiotics to prevent bacterial secondary infection. And this is something that doctors often do. So some doctors will prescribe prophylactic antibiotics for a severe respiratory infection. Others will say, no, we'll wait until the signs of bacterial secondary infection. And we do know that because we can tell that from blood tests, whether there's bacteria present. So personally, I would prefer to wait because I don't like giving out too many unnecessary antibiotics. But we could treat those infections very effectively. But then, of course, they would have no effect on the virus itself. The ventilation is if we need to... What happens with the ventilation is that there's fluid collecting in these air sacs, the alveoli. And what you need to do is like keep a constant pressure in the alveoli so that the fluids are pushed back into the blood. So you keep some fresh air in the alveoli. And with ventilation, what you can do is leave positive end pressure in the alveoli when someone's breathed out. You can control the pressures as the air goes in and out of the lungs quite precisely. And you can maintain oxygenation of the blood by keeping the fluid out of the alveoli for a period of time. Then you do that for a period of time, and what you hope is that the body's immune system will develop, the body's own natural immunity will then get rid of the virus. When we get rid of the virus, the inflammation and the acute respiratory distress syndrome should resolve, and we hope that these patients will make a recovery.
Okay, but we need enough ventilators to do that, and that seems to be the bottleneck everyone's talking about because...
We do. But if you or I, Brian, went into an intensive care unit now, being healthy, and were ventilated for a week, the risks of us developing some complication are quite significant. Ventilation is not a casual procedure. It's associated with a quite significant risks of its own. It's very much a last resort. And you're right, we need ventilators. But when someone's on a ventilator, you need an ITU nurse who's experienced with ventilators looking after them. You need ideally an intensivist to look after the patient's biochemistry. You ideally need an anaesthetist to look after the patient's oxygenation and airway. So for ventilation, for example, someone would either need an endotracheal tube or a tracheostomy tube to be able to breathe into their lungs. To tolerate that, you would need sedation. Very often you need muscle relaxation so the patient's muscles aren't fighting the ventilator. And for that you need syringe drivers, you need the right beds, you just need a whole host. It's the whole host of really quite complicated care as well as the ventilator. So you're right, we haven't got enough ventilators, but we actually need more than ventilators. We need a lot of drugs. We need a lot of syringe drivers. We need a lot of specialist nurses and doctors as well.
So,
and at the moment, we just probably got enough.
And so are we kind of missing the point when you see, I mean, because now General Motors in America is offered to make ventilators, and we're talking, I think I've heard realistically they're not going to be ready till June, but that's not necessarily the bottleneck. It could be all of the staff and the drugs and the beds and everything else. So that's not necessarily a solution in itself.
Any bottleneck you can get rid of it. So the ventilators absolutely would be a bottleneck. So if we can have plenty of ventilators, then that is going to be a massively good thing. And we need an awful lot more than we've got, potentially. It depends how effective our preventative strategies are.
Okay.
So rather than, we need to get ready, of course, flat out, more ventilators, more training, absolutely everything. But to me, even more critical is that we slow this pandemic down.